became a surgeon. So you can actually then approach to do some things, some course from overseas. So right now there are a few trainees I think there are about 20 trainees with Richard right now. All right, so they have the training, they were sent overseas, then they do their gazettement, then only they will be certified as a palliative care physician. So for me, I am not holding any of the, what they call it, the paper qualification. I'm one of the few, what they call it, we call it the old timers. So we are we are under the grandfather. Yeah, under the grandfather clause, you know. So we don't. I did not have any formal paper qualification. I started off to do palliative care with Richard. Then I went to work as an with NGO. I think in total about 10 years before I come out as a private. So for me, I'm actually a GP with a palliative care interest. So so under the qualification, I'm not able to register under NSR because I don't have the paper qualification. But because of my experience over the last 16 years, people are recognizing that I'm actually the expert in this field. So for those who are interested, I think the best person to actually approach is actually Dr. Richard Lim, for he able to guide you. So for now, we have palliative care in almost all the major cities in Malaysia. Yeah, so most of the major hospital, like general hospital, have a palliative care team there to support the community.
Who is Dr. Richard Lim?
Dr. Richard Lim is he's actually the head of palliative care in Malaysia. He's actually practiced in Selayang Hospital. So we all started off in Selayang Hospital. I mean, for ministry, yeah.
Okay. The thing is that sorry, before so a lot of the GPs can actually provide palliative care to patients, right, in the outskirts or where there is no big hospital having palliative care. There can be like a GP with special interest in palliative care. We can train all those, right?
Yeah. So actually, the GP, my colleague has been helping me a lot, because you know that not that's part of my presentation, how GP can help us in pain management as well as palliative care. Yeah. So they have, so far, they have been helping me to those places without palliative care specialists. Yeah.
Okay, come, we start then.
All right, just let me okay. Okay. Good evening, everyone. Thanks for coming to this webinar, and I'm Felicia. So I think some of you may have heard about me or know me for quite some time. I think I have a few people who are here that they say they know me. So what I'm going to do is, how can general practitioner help palliative care team, or what is their role in cancer patient and their pain management. So I'm speaking it from experience, because when I was doing locums in a few of my friends' clinic when I was a bit younger, I also feel some challenges when dealing with cancer patient. So most of the time when I see them, I say, oh, I'm a bit fearful of handling them, and say, okay, why not I give you a very simple pain management, but would you like to go back to your own oncologist? And if you have a palliative care physician, to go back to them. So what are some of the roles of GP that they can play in supporting our cancer patient in the community? So what I'm going to do is like, just going to give you two major roles that I felt personally that will be able to, the GP can help with their own patient, right? So we have a very classical example of someone having a cancer, a metastatic cancer. Then they present with something new. For example, you have cancer, then you were undergoing treatment, then you finish your treatment, you were well. One day you have a pain, you go to the GP and say, oh, you know, doctor, today I actually have my pain over the back. The initial assessment, of course, the GP was a bit suspicious that it could be a cancer that have already recurrent and gone to the bone. We are very familiar with tramadol, so he would have given some IV tramadol or some analgesia, like for Celebrex, but the pain was better, but it came back again. So our GP colleague will refer that back to the oncologist. A scan would have been done and it would be spread to the bone. So oncologists, especially those having a palliative care team in the hospital, will be referred to for pain management. Will call us in for pain management, while the oncologists do the radiotherapy, hoping to manage the pain. Some of them did, but some of them actually after the radiation may still continue to have pain, and that's when our role comes in to control the pain. So what we do is like we are still in the hospital. We want to send them back to the home community. So we actually write a letter to the person who referred to us and say, look, thank you for sending this patient to us, and please continue the pain management. If there's anything else, please come back to us. So this is one of the important role where GP start to detect new symptoms or existing symptoms that's got worse, that they can communicate and they can handle the pain first at their level, at the community level, before sending it back to the hospital, where we can use imaging to help them to determine what is the cause of the pain. And this is what I think Betty had mentioned about. There are a lot of areas in Malaysia, especially in the interior, where we do not have any hospices, we do not have any palliative care service there. And thus what happened is like, I always find it hard to send patients back to the kampong, you know, or the small town, because I know the access of medication is very limited and the GP or the community may not know how to handle it. So we have one patient that was admitted to the hospital for increased ICP from brain tumor. Okay, then she was actually from JB, but he came to KL because he was visiting, and then he ended up with us, have severe pain. We did a scan, and then it actually shows that the brain tumor has gone bigger, but we are not able to give the radiotherapy because he already have completed a course of antibiotic for radiotherapy. So patient was given some injectable morphine because he's not able to swallow anymore. And when he insists of going home, family insists of going home for terminal care. So what happened is like, we try to call up JB itself. You have a few hospitals, but they cover only 10-kilometer radius from their the hospital or the hospices. So they come from an area like, you know, you need to travel about half an hour before they reach the general hospital. So that is where I call out to GP. You know, I have community of GP take, and I reached out to the MP Cam or MPCN. I can actually write into the Facebook and say, look, my patient is going back to GP. Is anyone willing to help me? So somebody will PM me, somebody will give suggestion. I will communicate with the GP, telling them what to do. So basically, I have a good discharge plan to tell them what are the medication, how to titrate the medication, and send them under the GP care. So the GP will continue to communicate with us. If there's some, I think one of the problem with communities, they won't be able to get morphine, injectable or oral. So the patient's family will come to collect from us, where we supply it to our existing patient, and the GP will help us to actually continue to monitor until the patient dies. So I felt that the second role, that which is extremely important in how can we then, how the GP can help us to be able to take care of the patient, especially they are from areas that they don't have any palliative care of hospice. Because GP have, we can see GP in every state, in every city, in every kampong, there is someone there to be able to be the liaison person that I can send patients. So for my personal experience is detecting new symptoms as well as transferring patient to a state with no hospice, and GP has been extremely helpful. My colleague has been extremely helpful to me till now. All right. So what we're going to go into the proper. So I'm going to introduce a little bit about palliative care and what are some of the model of care that we have in Malaysia, and of course pain management, and how can then the GP help us in providing pain management in the community. So there's a lot of definition about palliative care. WHO is very long. So what I'm going to do is to simplify it. It's actually the main thing is to improve the quality of life of people having life-limiting illness by managing the pain and other symptoms as they approach end of life, and also give them some psychosocial support. So quality of life is very subjective. You know, for me, quality of life is having meaningful life. Some people may not have that. They just want to have pain-free. So you have to ask your patient, what is the quality of life that you want to achieve, and see then how, as a healthcare provider, how can we then help them to achieve that? So just let me see. Okay. All right. So so what type of person who actually who are life-limiting? People are talking about life-limiting illnesses. Last time people are talking about terminal illness. So life-limiting illnesses are patients that you know that is not going to live fully to the potential of 72 years old. For example, if somebody having a very advanced cancer, you know that they're not going to live very long. Somebody who have motor neuron disease, they are declining, they will not reach the age of the normal death age that we have, right? So anyone that have life-limiting illnesses requires some level of support along the way, and I think this is where we can help them. So then the question is always, oh, Dr. Felicia, when can we refer to you? Who can we refer to you? So when can we refer to you? Because
you're lagging.
Of life care when they are dying, or some people say that, can you hear me? Can you hear me better now?
No, it's fine.
Can you hear? All right.
Yeah.
All right. So when to refer? I mean, like some say that, you only refer during end of life care when they are dying. A lot of misconception that palliative we are dealing with people who have life-limiting illness, different stages of the disease trajectory. So then how do you, can you hear me?
Yeah.
How do you refer? Yeah, I think my internet connection is a bit poor. All right. So this is what we call as a surprise question. So the question is, would you be surprised if the patient will die in the next 12 months or so? So if your answer is yes, then it's time to refer to palliative care team. So you have a patient there with you. Do you think he's going to live the next 1 year? If not, then this is time to refer to us. When I started off with NGO, I was with different hospices throughout. I think two of the major hospices when I was practicing. People always said, "Oh, we didn't know about hospices. We didn't know about palliative care. How do we? If we do not know how, then can we reach out to this NGOs or this hospital for palliative care services? So how do you know where to get help?" So in Malaysia. So Ministry of Health in public hospital, most of the hospital, the tertiary hospital have palliative care. For example, we are talking about in KL itself, hospital UM we have, UKM we have, Selayang we have, IKN we have, Putrajaya we have. Then we have UM is under education, UKM is also under education. So other state is the same. So like Hospital Ipoh, we have one palliative care specialist there, the Penang, Perak covers, okay? So Johor, unfortunately, we don't have anyone yet. I think there's someone visiting. So there will be always someone to handle. So who is the person in Ministry of Health who's actually taking care of palliative care patient? It depends on how interested they are in palliative care. Some hospital surgeons are in charge. Some hospital physicians are in charge. So it really depends on the hospital. And hospices, we have a lot of hospices in Malaysia. Majority of them are they cover only 10-kilometer radius from their offices. So for example, in KL, we are very blessed. We have about 5 of them. So we have Hospice Malaysia, we have Aspect, we have RCC, we have Chang Hospice, we have FHL, we have from the NGO part. So we also have from our side, from Beacon Hospital, we have a home care team as well. I think Sunway is also doing a home care team soon. So another commonly person who practice palliative care, provide palliative care is actually GPs. A lot of my patient friends are actually practicing some kind of palliative care service to their patient in their own setup. So it is actually quite, it's not that hard to find palliative care support in in Malaysia. So what do we do? People always talk about palliative care. So what do you think we do? Of course, our bread and butter is actually pain and symptom management. A lot of people who are initially not at end of stage, oncologists will refer to us for pain first. They find that it's when a palliative care team are involved, the management of pain is a little bit improved because we actually use our drug because we know our medication quite well. So we provide counseling for family members who are especially new to the disease, or not all people. Not all patients diagnosed at stage 1. Some patients are diagnosed at stage 4, and when they come with a very short diagnosis, people are lost. So our role is to counsel them, to guide them, to tell them what to do. sometimes they didn't know, should I go to oncologist? I'm having pain. It was like, I don't trust what people are saying. So sometimes some knowledge and information, we can actually guide them as to get which specialty to see first. So once some of my patients just come in with obstruction, so I refer them to surgeons first. Some of them actually have more lung problem, I refer to my chest physician first, So it really depends what is their need. Of course, we actually have grief and bereavement services. Grief and bereavement, grief actually can start before they die. Yeah? We have this something called anticipatory grief, in which before patient died already, family felt the loss of that person. So we actually guide them over this period, and after patient died, we actually follow up and find out how they are doing. And of course, if they're okay, then we discharge them. Otherwise, if you think that they need further psychological support, a lot of time we refer them to psychologists so that they can get a best support to deal with their grief. We have nursing and rehabilitative services. And of course, we do education and training. It's like what we are doing right now to get more people to get involved in palliative care, so that, one of my biggest wishes, every yet have the ability to reach any of palliative care services, so that they don't have to tell story that they hear somebody dying in pain. So I think that is one of my greatest desire, is to everyone have pain control before they die. So what was the normal journey that our patients go through? Of course, GP is very important. Most of the time when initially, they have problem, they go to their GP. So GP will be the one to, I think you should go for screening. After screening, they say, I think this is something not good. Maybe you should go to see the surgeon, maybe. So diagnosis actually is those who are in the community usually go to the GP first. But of course, during screening in the hospital, we will be able to detect either if the tumor markers is raised, we found a lump. After that, of course, they go for treatment. And after the treatment, if it fails, they will send to the palliative care. And after the palliative care, we send them back into the community. They either die in the hospital or in the community, or they die in the hospital. Our hope is that studies have said that most of the patients, given a choice, would like to actually have their end of life care in the community. So how do we work? In the hospital, we can either have a consultation. Hospital-based, we actually have consultation because we don't have our own bed. So in our Beacon Hospital, we are on a consultative services. So they will be admitting under a general ward, okay, where ours is like one room, one ward is for cancer patient, the other ward is for non-cancer patient. So they'll come under us, we consult, and then if the oncologist is the primary, then we support the oncology team. But they have also hospitals that have bed for palliative care. For example, in Selayang Hospital, they actually have a dedicated bed for palliative care. have dedicated bed for palliative care patient, and IKN also have a dedicated bed for palliative care patient. So in the community base, some hospices do 24 hours. That means they do home visit, but they also can be reached 24 hours. There'll be nurses on call that they can reach at all time. All right. Some hospices do home care, but they only say can reach us out during office hour. So this is this is what we practice in Beacon. My team can only be reached during office hour. After office hour, if there's anything that needed attention, we advise them to come back to the hospital. They are inpatient in, I think, Pure Lotus in Penang. They have inpatient they take inpatient to stay in Penang. And there's from hospital extended to the community. That means it's not independent as an NGO. So IKN have a team to go out within, I think, 20-kilometer radius. They have a home team to visit their own patient, and private side, of course.
You're a bit laggy. Sorry. So while Felicia is laggy, yeah, she's very laggy. Felicia?
Yeah. Can you hear me?
Yes, we can hear you now.
All right.
So you were lagging.
Sorry.
So I think you're at the private medical center providing.
All right. So for Beacon Hospital, we actually need if the patient cannot come, CCAP has said that we can only take care of our own so-called own patient. So for us, that means the first visit, the family member have to see me in clinic first before I can start my home care team, to send my home care team to see patient in the community.
I see.
So of course,
yeah.
So Yeah, because the thing is, I find it very beneficial because once they come in with a registration number, when I start to order for blood, what investigation or to prescribe them medication, it works very easy for us. So I think this is one of the requirement from CCAP that your patient has, you have to see, your patient have to be from Beacon. So if there's any GP that want to refer, can always call, let one of us know. I can see me in the patient doesn't have to come. The family just have to come to show me the reports and let me have a brief history. And of course, GP is do home visit when you can. So some of my GP do home visit. They actually go to the patient's house when the patients call them. Not many, because a lot of GPs are a bit worried that the practicing certificate, whether the address allowed them to do home visit. Actually, you're allowed. If you see into the requirement, you can actually see your own patient that from your clinic if they stay near you. Okay, this is the ideal multidisciplinary team. We want everyone to get involved. We want the nurses to get involved. We want the hospice to get involved. We want the GP to get involved. We want the care home to get involved, because at the end of it, patient with cancer can be anywhere. And if the more of us are involved and interested in caring for the cancer patient, I think we can make a we can make an ideal team for everyone. So this is a study from Australia, and I think it is the same in Malaysia. We have very limited, as I said now, I think it's so handful. If you look in the NSR to look for palliative care physician, you can hardly find more than 20. For a country as big as ours, we have only 20. So it is very difficult for us to take care of everybody. But if we are able to disseminate information, we are able to train people, I think the GP plays an extremely important role, because at the end of it, you are the one who will be able to help your patient in your own community. So normally by the time they come to us in the hospital, they have very complex symptoms, unexplained pain, extreme pain, confusion, So yes, in that case, we need to be able to have imaging. We need to get a full team in to find out what is the problem. But I think once patients are more stable, or even at the end of life care, you can see the non-complex patient. GP is the best person to be able to take care of them, because we don't have enough bed to keep everyone in for a long, long time. So I think if we can send them home and under the care of the GP, most patients would prefer that.
And the cost of it all on the patient's family to keep the patient in a hospital. Yeah.
Yeah, I think the the cost, unfortunately, the cost is quite expensive in private, unless you have you actually have a insurance that have no limits, right? Then I can prescribe whatever pain management I can give. Then I have the free hand. But I'm very careful, because most of the patients that come to us in Beacon, we are not the big players. We don't have very, very rich patients. Those are coming in with insurance. So our patients are mainly in the middle class with insurance. So we don't want to exhaust their insurance as well, because first, home care is not covered by insurance. Palliative care itself is not covered by insurance. But
palliative care is not covered by insurance.
No, none of the insurance is covered. Overseas insurance, yes, but not Malaysian insurance. So that's our limitation, is how can we then still able to help our patient with pain management when they cannot afford. All right. So a lot of time we do what we can in the hospital, because we send them to CSR. We write in the insurance, we actually write pain management. Pain management is covered. Then if you write palliative care, they won't cover. You write end of life care, they won't cover. So we have to be very careful as well, because we want them still to get some pain management. But once they're at home, if they cannot afford us to go into the house, we refer them to the NGOs. And if they can go back to the GP level, their GP definitely charge cheaper than us. So I think they have help in the community if we are able to find the access. So yeah. So okay. So pain and symptom management is very important. This is how our GP colleague is going to be able to help us. All right. It's mainly because they have built this trust. Sometimes I talk to my patient. Oh, I'm going to send you back to your GP. And they feel fine, because they have built trust over the years as their primary care doctor. Oh, they take care of my mother, they take care of my father, they take care of my brothers, the whole Chang bang is with one GP. So I think the trust is so important. Most of the time when the patient come to us, we only have very short time with them, in days to very short weeks in the hospital. So I think the GP with the trust, they can actually help the patient to understand palliative care a little bit more, pain management, support them psychosocially. So they can also give information. They can tell them where to get, just like what I've shared, where do they get palliative care, where do they get the pain management. And they can be the liaison person for patient and the hospital team. For example, when patient goes to the community, if they're not under my home team, I don't know after that what happened to them. You know, NGO doesn't report, hospices doesn't report back to us, but GP sometimes, they're very nice, they write letter back to us when things are, you know, they write to us, oh, I've received a patient, thank you for your referral. You know, I'm very happy for those kind of letter, because then they can become a point where we can connect.
Actually, can even WhatsApp. Sometimes we are so easy with our numbers these days. You can always WhatsApp us to see what's the progress like.
Yeah, but I don't look for other job for like you lah, for other people lah. Then of course we rely very heavily on GP to detect new symptoms. You know, patient who's breast cancer, you know, suddenly cannot walk. This is an emergency. We call it spinal cord compression, right? GP will have the first person. They first will go to the GP and say, hey doctor, I have pain yesterday. You know, yesterday I cannot walk. Then they set an alarm and GP will send it back to us as soon as possible. Or, you know, sign of symptoms of hypercalcemia. And more importantly, after patient died, GP can help us to continue to support, because the other family members still go back to see GP, ma. You know, oh, how are you? You know, your dad passed away a few weeks ago. How are you coping? You know, so they become a very good family support for those of my patients' family who have lost their loved one. Okay. So this is one study that I've done some years ago. It is an online study, and I want to find out among GPs, what is their concern about palliative care? All right. So actually, we have about 128 respondents, and the survey was for about 2 weeks. So these are the three group of close group that I actually asked and put on the survey. So if you look into some very basic question. So if you look into the first one, actually, what would you consider is your main barrier for providing palliative care? It is the lack of skill and knowledge about palliative care. And this can be learned. The best thing is that it can be learned and it's easily learned. You already have the basic being a doctor, right? Probably you need to read a little bit more about pain management. I'll give you the CPG towards the end of the course, the pain management. Just read more. Don't understand, ask. You know, there are people who are willing to teach. And you see, if you look, lack of interest is only 3. There are actually people who are not interested, which is fine. You know, people have choices. But those who are interested, they actually want to learn, reach out, then we can give more talk. We can actually teach more. And they said they prefer palliative care to be in charge. I think this is when the symptoms become very complex. Right? They do not know what to do. But as I said, we can give you a good discharge plan so that you can follow up with what we do. And what are the challenges that you face? The one that pain management actually is not very high. It's only 15%. It seems that they are very quite okay with pain management already. They just need a little bit of fine tuning here and there. But I think one of the things that they find it hard is actually end-of-life care. And it's not surprising because end-of-life care can be quite distressing. They have quite distressing symptoms. Unfortunately, I'm not going to talk about the end-of-life care symptoms here. I'm just going to concentrate on pain and pain management. And if you look into the workshop, what would they like to know? You see, they want to work as a team. And this is what we want to, you know. If we can work as a team, you know, how much can we help our patient? All right. So this is my suggestion for my GP friends who are here today. All right. You already have a clinic set up. Okay. Do not be afraid to deal with pain. You know, don't understand, read about it, and you can focus on it. For those who can go out, you know, you have a community of patients that need your help in the community. Sometimes I understand because I actually asked my colleague who said, hey, why don't you go out? He said, oh, I cannot. I go out. 1 hour go, 1 hour come back. I have 20 patients waiting for me in clinic. How? I will have what do you call that? My income will be affected because I go out and see 1 patient, but 20 more patients waiting for me. So I think maybe what you can do is like set up once a week, you know, for a certain hours just to do that home visit. It may be very helpful, especially if it's near your clinic, right? So you can visit home nursing home. A lot of my outpatients are actually in nursing home. It's not that the family didn't want to take care of them. They have limited resources. They have to work. They don't have the expertise. So some of my GP are making rounds in a nursing home to help with the symptom management. So let's go into cancer pain management. I think, as I said, it can be, the information is all in the CPG, but I'm just going to go through very briefly about cancer pain management. we actually know that pain is very common in our cancer patients population. So at all stages, is 53% of them actually experience pain in all stages. But when they have advanced or metastatic cancer, almost we found that almost 89% in our own Malaysia palliative care unit, almost 90% of them have pain. And most of this pain are undertreated. It's either because the knowledge and skill is not there, or people just are so afraid of morphine or opiate phobia that they didn't want to take morphine. So what could be the cause of pain? Everybody think, oh, the pain is caused by cancer. Yes, but how? You know, it can be caused by the tumor, the size of it, the bulk of it. You know, that can cause pain. Cancer treatment, we have surgical wound. You know, that can cause what do you call that pain. Chemotherapy, those with platinum base, they can have neuropathic pain. It's a long-term what do you call that pain, and this doesn't go away. Radiotherapy can cause fibrosis. It can actually cause necrosis. Those causes pain. And of course, a lot of people say, oh, alternative treatment doesn't cause pain. One, I have my experiences. They also cause pain, you know, but they didn't. They will think that the pain is good for them. That's a different, you know. So when you're going for alternative treatment, it causes pain. I'm not putting down any alternative, because I also believe some of them are very helpful. But a lot of time, the words that they say, you know, you have to endure the pain, because when you have pain, that means you are alive, and then you should go through the pain, because that shows that my treatment, no pain, no gain. But sometimes when you have,
oh my God, I never heard that.
you have a stage 4 advanced disease, you know, you have existing tumor that it will not go away. But asking patient to endure the pain is actually quite cruel and quite unethical. Of course, we have metastasis that has gone infiltrating to the nerve, lymphatic system, brain, is spread to the bone. All this actually causes pain. So our role is to find out when the patient is having pain, where does the pain comes from this list. So pain can be somatic, it can be neuropathic. Somatic organs, it can be a hollow organ like visceral pain. You have gastric, it's a visceral pain. You have liver capsular stretch, it is a visceral pain. You have a colicky pain, it is a visceral pain. So musculoskeletal, it is your bone, it is your muscle, you know, you have a skin nodules, those causes pain. Those are the somatic pain. You have a neuropathic pain. It can be central, it can be periphery. Basically, the pain description is a bit different. So what are the different causes? So some of the musculoskeletal, you have a fracture from the bone tumor, okay? That causes musculoskeletal pain. You have, when you are immobile, the muscle gets very stiff, there's musculoskeletal pain. And I've already explained visceral and neuropathic pain. So the message is pain history is extremely important, because each of these pain require different medication. Morphine doesn't work for neuropathic.
Okay, we're losing you again. Your line is quite laggy. Sorry, Felicia? Okay, maybe you guys can start.
Morphine doesn't help in.
Sorry, Felicia, we lost you for a while. Maybe you guys can start thinking of questions to ask her.
Yeah, okay.
Okay, so we lost you for a while.
Okay, sorry, I think my internet is a little bit unstable. So I said pain history is very important. The reason is because this different type of pain require different medication, and morphine doesn't work for all. Morphine doesn't work for neuropathic pain. So that's the reason why you must find out what is the source of the pain. This pain history, you can read about it.
Bad. It's the worst
let me
kind of
see.
pain. I have it before. Neuropathic pain is the worst kind of pain.
Yes,
I had this nerve impingement due to a cyst in my spinal cord. I went through hell.
Yeah, neuropathic pain is not that easy to treat as well.
Yeah.
So I think the main thing is like the whole thing about pain history is to find the source of your pain and treat it. So you can read about this later. And how do we assess pain? It's good to have a very objective measurement of pain. So this is a pain score. So we use this visual analog scale. That means we ask the patient 0 to 10. 0 is no pain. 10 is the worst pain possible. Which level are you now? So what we can do is like we can close the upper part of the numbers and tell them the picture. Just show me which picture and correlate it to the numbers. So let's say if I point to the last picture, it is 10 over 10. If I point in the middle blue, it is 4 out of 10. So this is important because when we start our analgesia, we want to see how effective it is. All right. But some auntie don't know what, no. Some uncle I say, what are you talking about? What is 1 to 10? I don't understand what you're talking about, right? So, auntie, today if your pain is 100%, after medication, how many percent it reduce lo? Then you take as a guess lo, you know. 細痛啊、大痛啊、中痛啊, you know, you ask about mild, moderate, severe lo. So you can use your own way, but this is a standard that we use in the ministry as well as in a palliative care setup. It become our 5th vital sign. So of course, this all you probably will know. We do whatever we need to determine the source and type of pain, and we do simple blood tests. So hypercalcemia can cause severe bone pain. You know, if your calcium levels is increased, it is an emergency, especially those patients with squamous cell carcinoma, with actually bone metastases. You know, so they have a tendency to have hypercalcemia, and if there is a hypercalcemia, we treat it, the pain will come down. Simple X-ray will tell you about fracture, ultrasound, liver capsular, and then PET scan if necessary to see whether the disease has progressed elsewhere or cord compression. So when you find the cause of the pain, the question right now is, can you treat it? So if you find that it is a fracture, if you can fix it, fix it. Whatever that can be fixed, please fix it. But if those patients, like for example, I have a patient with headache initially, we cannot fix the cancer anymore because he already received the radiation. So we can only treat the symptom. So if you cannot treat the cause, please treat the symptom. So not everybody think that, you know, once you're in palliative care, it's all morphine. It's not really true, because if let's say patient have a fungating wound, I still refer to my oncology colleague for radiotherapy. Some of them actually can do well with surgical debulking or chemotherapy to reduce the tumor burdens, thus reducing the pain. For bone pain, NSAID is very good, COX-2 is very good, bisphosphonate is very good, but be very careful because I have seen polypharmacy. Patient comes in with Acoxia, Voteron, and a Voteron gel. So actually patient ended up with upper GI bleed. So a lot of people felt that, you know, your Voteron gel or your NSAID gel doesn't cause a GI problem. It does, because it still gets absorbed into the blood system even though you apply it. And don't forget, when patient applied it over the skin, it's not that one dot, you know, they go to sapu all over the body. So the surface area of absorption become very high, and they actually end up coming in with gastritis. Be very careful on NSAID. If patient is on steroid and then you give NSAID, then the chances of GI bleed is much higher. So make sure that you cover with PPI. And neuropathic pain, of course, like what Betty have mentioned, the nerve pain is it's not easy to treat, but we have a lot of medication that we can use. Okay, I will show it to you later. And tumor pain, opioid is still the best, and NSAID. So this is a WHO ladder. So when patient comes to us, if they have mild pain, I don't start morphine first, you know, I start with non-opioids, PCM, you know, I start with NSAID, you know, I start with adjuvant like, you know, neuropathic. I have a patient that came in yesterday, 2 days ago, with severe neuropathic pain over the thigh because there was a compression over the nerve. I didn't even start her on opioids. I just put her on gabapentin and her pain is relieved. So it's not necessary to start every patient with opioids. And gabapentin and Lyrica is something that you can get it in the community. Tramadol is something that you can get it in the community. So for pain that is mild to moderate, score of 4 to 8, okay, we can do with tramadol. Weak opioids, we do with DF118, you know. But when the patient come in with severe pain, we do use strong opioids like morphine, fentanyl. We do use oxycodone. And of course, if neuropathic pain, certain hospital, they use ketamine, certain hospital use lignocaine as well. So for the level of community, we don't go up to anything that is not available in the market for those GPs. So because we wanted to encourage patients not to stay in the hospital for so long, even though some of the patients going through injectables, but at the end, we want them to take by mouth. Ladder is the ladder, WHO ladder that I show you, and by clock. So this is something that I've learned over the years. Patient is advised to take morphine only when you're in severe pain. You know, oral morphine works. Once you take oral morphine, it takes 45 minutes before it starts working. So when your patient has pain score of 8, by the time you take the morphine, waited 45 minutes, the pain score will be 10. So don't tell your patient to take medication only when you have severe pain. If they have an existing problem, that means they have a cancer in their body which is growing, they need regular medication. So normally what we do is like for morphine, if you do not have renal failure or there's no renal impairment, it's 4-hourly and PRN. I will explain it to you later. But if you have renal impairment or liver impairment, then it will be 6-hourly to 8-hourly and PRN. So let's just go to some of the opioids that we use. Okay, syrup morphine up to now, I think GP cannot get. So most of this would be given out by oncologists or palliative care physician in the hospital, discharge them to the community or by the hospices. So the starting dose, although it is sometimes advised to do 5 milligram 4-hourly PRN, my advice is start low, go slow. Because if the patient, you start too high, patient have side effect like vomiting, dizziness, they will never trust you again. So I usually start a little bit low, tell them I need about a week, 5 to 7 days to control your pain. You be patient with me. Manage the expectation first, okay? So 4-hourly PRN means if let's say I do 8 o'clock, 8, 12, 8, 8, 12, 4, 8, 12, 5 doses, right? So then in between, if you have pain, that is your PRN dose. So if you are taking at 8, your pain comes at 10, you give 1 extra dose at 10, but the 12 o'clock one you don't miss. So the 4-hourly one you shouldn't miss. The breakthrough is the extra dose. And that's how we calculate what to give the next round. So let's say you take 3 or 4 extra dose in that 24 hours. The next day we increase 30% of your syrup morphine. So that's how we do the titration. So if you are not familiar, I think go to the CPG, they will be actually help you to do the calculation. PCM 1 gram 6-hourly. Sometimes if you have liver tumor, you have liver capsular pain, I still use PCM at a lower dose because Panadol and morphine actually work synergistically and enhance each other in an analgesic effect. And bone pain, of course, we have Celebrex, Lotron, Acoxia, we have Dynastat, we have a lot of things, but I think the common one is the first three. And I think, as I mentioned, be very careful because a lot of our patients is already if those who are elderly, they do tend to have problem with gastritis and heart problem. For liver capsular pain, it's if you have a liver enlargement or hepatomegaly, because either it's a primary tumor or it's a secondary, it stretches the liver. So when it stretches the liver, there's a lot of inflammation around it. The steroid dexamethasone is helpful. I don't really use a lot of prednisolone, but I know GP does. The reason is because I'm more familiar with steroid. So for dexamethasone, for steroid like dexamethasone, there are worries that if you start patient on dexa, after a while, you need to taper it down because you didn't want them to have this withdrawal symptoms, right? But studies have said that if you give it within 2 weeks, you can just stop it without tapering. What I meant is that, for example, I'm putting a patient on DEXA 8 milligram for the liver capsular pain. So I give DEXA 8 milligram daily for 2 weeks, I stop. So the inflammation would have reduced by then, the pain would have reduced by then, and if it's not, I use opioid. So for neuropathic pain, if you're on DEXA, please cover your patient with some PPI, either with Nexium or some pantoprazole. So for neuropathic pain, this is a very old medication, amitriptyline, which is also very commonly used in the community. Amitriptyline is actually a TCA, an antidepressant. So a lot of people, when you start amitriptyline, be very careful. When they search for it, it's actually an antidepressant, and they think that you're treating them because they're depressed. You have to explain to them this is a pain management. So we started off 25. If your patient, you can go up to 75. 75 actually is the antidepressive dose. So if your patient is already depressed and have a neuropathic pain, it's also good to start 25, then slowly titrate up to 75. But I don't like amitriptyline. The reason is because the anticholinergic effect is very bad. They have very bad dryness over the mouth. Their mouth becomes very sticky and they have urinary retention. So I prefer to use newer medication like gabapentin and Lyrica. Carbamazepine, I know Dr. Mary Cardosa, she uses it a lot, but I don't use it very commonly. I use a lot of GABA and Lyrica because I find it's quite effective. So if you have a neuropathic pain, you want to start on gabapentin, do 300 milligram on night. 3 days later, do it BD. Then 3 days later, titrate up to 300 TDS. So you can do with Lyrica, with a BD dose. You can start with 50. You can go up to 150. So you just need to learn how to play with your medication. But I think I want to also focus on the pharmacological aspect of pain management. All right. Surgical debulking is important. If you have a very big wound, especially the breast wound, sometimes it's very heavy and it's very painful. So by having a surgical debulking or a radiation of chemotherapy to reduce the size of it, it actually helps in pain management. A lot of patients was advised not to shower when they have a fungating wound or nodules. But we told them that it is okay, you know, just go to a shower, give it a good rundown so that all the debris come out, then dab it dry, okay, and then you can dress your wound with whatever dressing material that you're using. So when I was in hospice, we actually put the patient in the shower and shower all this wound one off to clean, so that at least patient also feel they are clean, because otherwise they will be just being bed bath, you know, they don't feel the cleanliness. And of course, management of lymphedema, you know, we can refer to your your physiotherapist to do lymphedema massage. We can actually do lymphedema pump to reduce the size of the lymphedema, which help in reducing the pain related to the stretch because of the size of the fluid. Huh? And this is something that we use distractive therapy. You know, some patients are no pain when you talk to them, no. You talk for hours also, they have no pain one. But then once you stop talking, the pain start to come. So we know that we can use certain distractive therapy to help them with that. Of course, mindfulness therapy, a lot of people are practicing mindfulness, being aware of where you are at this moment, so that, you know, you don't think about and focus on other things. And complementary therapy. I would like to just bring you to, patient will go and do anything they want, you know. They will tell you, I actually take porcupine powder, you know.
Yes.
They will tell you that I take Sabah snake grass, because they are desperate. You know, you cannot really fault them, because at the end of it, if you ask me, the oncologist cannot offer you anything anymore. Then where do you go? So people are seeking help. People are seeking hope in alternative. And if you say that, oh, how can you do that? And you judge them, they will not come to you anymore, because why should I come to a doctor? You cannot provide me anything. I have some sensei who's going to tell me that I'm going to live longer. Who am I going to follow? So sometimes I'm a bit lax in that. I said, okay, whatever you do, you tell me, right? So that I know whatever you do and I know what I do. So that my side effect I can tell you, but I cannot tell you the other side effect. So if things are happening and I know it's not from my side, my medication, it could be from your medication, then you have a choice to stop it or not. You know, so we know herbs can actually cause a lot of liver failure. We have problem with platelet. So that's the reason when they said, oh, doctor, can I take my chemo with my porcupine or whatever? I said, oh, ask your oncologist, but we advise not to, because we do not know the interaction between them. But things, acupuncture, I find it is very useful. My colleague, Dr. Kun, actually do acupuncture. She do it, it is a dry needling. It is not, I don't think so they really follow the meridian, but they have their own set of acupuncture point, and it helps in the neuropathic pain and muscle stiffness. But we are all very, very careful before you advise a patient to proceed with acupuncture, make sure that platelet is okay. A lot of patients are on antiplatelet. A lot of patients have thrombocytopenia related to the cancer. So if you have bleeding tendency, you pop, then massive bleed. So be very careful what you advise. And of course, a lot of things are coming up with medical cannabis. Okay, it helps in pain and it helps in relaxation. And I believe a lot of the GPs are also very interested in medical cannabis. Learn more about it. As I said, I'm very open-minded. Learn more about it, so that if there is any way, but it is illegal in Malaysia. All of you know about it, but it is in the community. I have patients showing me opium also in the community, get from China shop, one of the medicine shop. Everything is in the community. You have to be aware, but you have to be aware of what to tell your patient, how to support your patient. But the moment you say, oh, let's say Taima, don't come and see me, habis cerita, you cannot help your patient already. So be open-minded and help them, all right? But don't get into anything illegal, what I'm saying, you know? So this is the CPG. You can actually type CPG for management of cancer pain. The whole PDF file format will come out. All right. And all that I speak of, actually, you can find the information from there. So for now, I thank you for your attention. And I think I should go to the chat and find out what was the question.
Okay, there's no question at the moment yet. We will take questions now. Let me, okay, while we are waiting, maybe I should share my screen. Okay, let me share so that this is what they are also waiting for. Okay, let me see. One participant. So basically, this is it. Okay. So this is the CPG. This is the CPD point. You can scan. If you scan, you use the MMA event app. Okay. From the event app, you also can scan. Felicia, we get 1 point. So then after which go to scan QR code.
Okay, done.
Yeah. Okay, I'm also done. So if you are unable to scan, okay, please get back to me, either message me or on Telegram or WhatsApp will be best lah. Message me on WhatsApp, and then with your name, your IC, MMC number, and your email address, we will do it manually for you. Okay, so is there any question? So Farah now Sahira said, okay, it's actually cannabis or ketum?
Ketum is okay or not? As I said, both of them are actually illegal. Okay, so you have a patient in the ward ongoing chemo, but they take ketum. Okay, so you do not really know actually what interaction it will have. You have I would advise the patient to tell them to find out why they're taking the ketum. You know, what is the intention of taking the ketum? If the intention is taking ketum is for pain management, my advice is that we have also a very good pain medication, which is actually we know the side effect, we can manage it better, and then ask them whether are they willing to get somebody in to have the pain management done. So if you can offer them something in replace of ketum, because ketum I don't know how many ml inside got what, you know, so very hard to assess. But I think ketum is quite famous is because it is there in the community. All right. So my advice is, I do not know how ketum interact with chemo drugs. Okay, but we know of a medication that doesn't interact with the chemo drug but can give you the pain relief. So I'm not sure. So it's okay or not? Cannabis is illegal, but if you tell them it's illegal, then how are you going to report them or not? So it's also an ethical issue here. Huh? So my answer is offer them something that is legal, and that is what the CPG says, and it may give you a better pain management. Assume all cancer patients in palliative care have pain. Well, I have patients that don't have pain, but I have a patient have very severe breathlessness. For example, I have a patient with CA lung, have no pain, but palliative care, but they have more respiratory symptoms than pain. I have patient have brain tumor, have actually no pain, you know, but they have confusion. Okay, so we deal with the confusion. So not everybody in palliative care or cancer have pain. Is vitamin C contraindicated with folks when treating colon cancer, referring to the study with the help with cancer? Okay, this one you have to ask the oncologist. Vitamin C is injectables or oral? Injectable vitamin C has very high what they call that? What's the word they use? Vitamin C, very high. Sorry, suddenly I have a brain the block. Vitamin C is also injectable. Vitamin C is also not allowed in Ministry of Health. So when
not allowed for what? Not allowed as in
IV vitamin C is not actually allowed
as a drug, huh?
Yes, as a treatment. It hasn't been proven. I mean, like they haven't accept that it is a proven. Oh, sorry, the word is antioxidant. So it hasn't been allowed to do IV vitamin C especially in the ministry. So is it contraindicated for folks? I do not know, but I know people are using vitamin C as a very high antioxidant to treat tumor. So for Ethan, they are referring the studies with cancer. I'm not sure which studies they are talking about, but I think that if they ask you, is it allowed? I think you just have to be honest and say, like, what I tell you, I do not know. It's not allowed in Malaysia, but if you can find more studies and some doctor who are willing to give it to you without having their license being revoked, then please go ahead lah. Yeah. Can Lyrica be given with antidepressant, but both in low doses? Which antidepressant, Siva, Sivandan, which antidepressant you are giving?
Okay, while Siva is typing here.
Okay.
Okay.
Yeah, he's
we
trying to
have
go
one.
to Singapore.
Yeah.
Yeah.
We wait for Siva's question.
All right.
Answer first. There is a lady who asked on Facebook, Chia
Mm.
Mei, say,
Mm.
oh, hi, very interesting talk. Do you
Okay.
manage pain in PEDS patient?
Yes, I do.
She
Okay, so
does.
I'll come back to that. Okay, so can Lyrica be given with amitriptyline? Okay, so it depends on the indication. So Lyrica, you give it for neuropathic pain, but amitriptyline, you give it for antidepressant. You can give it together, and both of them have neuropathic property. But the side effect of that means your antidepressant is already a 75 milligram, right? Siva, because amitriptyline only have antidepressant effect when it is 75 milligram. And by the time you have 75 milligram, you may actually take off the Lyrica already. You don't need two to control the neuropathic medication. So you don't have two medication because both have side effect. So you want to remove one if the second, like antidepressant, is working in the neuropathic pain. Yeah. But if you want to use both those, it doesn't, you just have two drugs with two different side effects. So you don't want that. Yeah. So
Okay.
come back to the pediatric side. Yes, my special interest in pediatric palliative care. I'm very involved in PEDS palliative care for a long time. So what we do with pediatric palliative care is actually those calculations. All right. So if you actually look into the CPG, we have like 0.1 milligram per kilo per dose or something like that. So we do according to the weight. But sometimes what I do is when my patient is in pain, for example, if my patient has solid tumor, I have a young child with very rare 4-year-old girl with very rare liver tumor, and she's really jaundiced. So people are worried, oh, you give morphine, then your liver function is not very good. Actually, I said, you know what, when patient is in pain, you deal with the pain. So I titrate. I sit down there, I give 1 milligram. Okay, how is the pain? Okay, not good enough, I give another 1 milligram. So I do on the spot titration for my patient if they're in severe pain. But if not, the principle is still the same, 4-hourly PRN. And same as gabapentin, we do lower dose. We just have to calculate, like your friend Shan, you just calculate everything in kilogram per kg lah. Just get the right dose. We do pain management. But children, I find that another way to work with them to get pain management is actually, I use a lot of games. I use a lot of play. Distractive therapy, it works fantastic with children. I have a patient, I think probably she's about 9 years old. I use Barbie doll. You play with her, no pain one, Okay, then you have to know what Barbie
you get to play also, right?
I also get to play. So for boys, I used to have sandbox with soldiers, and I use a lot of art therapy to find out what is their concern. I use a lot of crayon. I use a lot of what do you call that? Play therapy, art therapy, music therapy with the children. I think adult we can work with that as well. Just that nowadays a bit hard to find out about that.
Your
Okay,
job is you need to be very strong for your job to be a palliative doctor. I feel.
I think children one is very hard for me. When I first my first baby died, the 4-year-old girl who have hepatomegaly died. I actually broke down. I tell my boss, the time I was working with one of the NGO, I tell my boss, I don't want to do pediatric already. Give me adult. I don't want to do pediatric already. So I ran away to China for 2 weeks. Cannot tahan, cry like mad. Then God said, hey, if you don't do, who's going to do? Because you're the few pediatric palliative care physician that can help them. If you don't do and you don't train, who's going to do it? So say, come back and do again. So I've been seeing children as well.
Okay.
Would you like to know any criteria? If that's a surprise question that I spoke about. If you think your patient is not going to live for the next 12 months, okay, you can refer to us. And palliative care depends, life-limiting illness is a very broad spectrum. Some hospices only receive cancer patients, advanced cancer patients. Some hospices receive end-of-life care. A lot of the hospital accept end of life care, but for me, I receive patients that we know the prognosis is not very good, even though they are non-cancer. So if I have a patient have a very severe heart failure, which I think that they have prognosis less than 6 months, I will see them. Okay, if I have an MND patient, so I have a lot of patients with motor neuron disease, I have a lot of patients with liver failure, heart failure, all the failures, organ failures, and also have a geriatrician has been referring for very advanced dementia, so there's a lot of counseling about whether we should tube feed them or not. So a lot of talking to the family, trying to understand why did they, patient is there, but they are not there, that's the counseling coming part. I talk to them what is the importance of if that's what they want. My NMD patient, actually, one of my patients say, don't tube me when I cannot swallow anymore. But the family said, hey, you're going to die of hunger. She said it's okay. So we actually respected her wish. The moment she cannot take orally, we don't tube her. She lasts for 2 weeks. She passed away the way that she wants. Yeah.
Okay, I have a few questions. Okay, myself. Okay, so now I like the idea actually of GPs having their own special interests. Okay, of course you are the ultimate goal where you can actually be a GP and then have an ultimate interest in palliative care and then eventually becoming a palliative care physician. But of course, GPs can take interest in the palliative care. Like I say, do they need to know or understand a lot of oncology diseases?
Well, I mean, it's very helpful. Okay, my experience is when I was purely a palliative care. So I was trained from Selayang, I'm a palliative care. NGO, I'm a palliative care. So my view is very narrow. I never believe in radiotherapy for stage 4 disease. I never believe in chemotherapy for stage 4 disease because I said people are already so charmed already. You still give chemo when patients have less than 6 months of prognosis. You know what I mean? But when I come to Beacon and start to work with the oncologists, I try to understand why are they actually still giving chemotherapy when they're stage 4. Okay. And knowing why and seeing it happening in front of me tells me that my views are very narrow. So understanding the oncology part is important. All right. For example, I have a patient that comes in with spinal cord compression. Without the radiotherapy, she will be paralyzed. Okay. But we know that we cannot cure the cancer, but we can deal with the symptom better once the oncologists are involved. So a little bit of oncology. A lot of the palliative care registrar, they actually work with the oncologists so that they can understand the psyche, why they do certain things, right? So for me, I think, yes, for me, my experience with oncologists have helped me to be a better palliative care physician.
Okay, another one is actually, what is your view on euthanasia?
Very, very hard things to answer.
Yeah, because I'm very interested because I feel like I believe in it.
Okay, I don't.
Oh, you don't?
Yeah, why would I say that is because I believe, because a lot of patient comes to me and said, doctor, can you give something for me to end my life or not, right? It's a very common question that I get to ask a lot of time during, in a week, I probably get 1 or 2. So the question I would like to ask them is, why would you ask for euthanasia? And I find that most of the time, it is because they're in pain or they have some kind of symptoms that are not being controlled. So they find that it is a lot of suffering during that they have to endure at the time. So it is actually a call for help. So my question to them is, if I can control these symptoms, would you like to end your life? I can tell you 90% of them will say no. They just want their symptoms to control. So someone asking for euthanasia, the first thing is a red flag to say, please help me. Nobody is listening to me. I am suffering from pain. I'm suffering from depression. I'm suffering from symptoms. Please help me. So that is my stand. How about the other 10%? They really felt that the problem is the existential suffering. That means they said, you're useless already. Why am I being a burden to myself? Why am I being a burden to my family? So that is when the counseling come in, to help them to find meaning even within the suffering. So that euthanasia first of all, it's very easy for us to say, oh, Malaysia, it doesn't allow, it just, we brush it away, But I think at the end, when someone is asking for euthanasia, is the question you want to ask them is why? Why are they asking for it? And if within that question, why, is something that you can provide pain management, symptom management, psychosocial support, and they can help them to endure the suffering. You can never take away the suffering. We are not them. But if we can at least help them to take one step nearer to be happier, to be more comfortable, I think that will actually stop. Not say stop, they'll still think about it once in a while, but they will not think about the euthanasia. So personally, I don't believe in it. It's because I think we have undertreated or missed out a lot of the symptoms because we brush our patient away.
I see. I don't see it as such. I see it as what do you say that? As a choice. Yeah, a choice. Anyway, coming back to another thing is actually we're talking about opiates. Of course, their life is shortened, but will they get addiction or not? The reason I ask you is because 5 years ago, when I actually had a tumor, which is actually sarcoma, and I had a massive operation done, I was in a lot of pain, and I developed a craving for Petidine. Okay, even when I was discharged, I felt like I would like to go back to the hospital for Petidine. So do your patients act in that way?
All right. Petidine is addictive. That is the reason why Mary Cardoso, so Dr. Mary Cardoso is the first pain specialist in Malaysia, and she used to be my boss, and she hated this medication because it is addictive. You can get addiction out of it.
Right? Yes.
But for opioids,
not so much.
Petidine, and you have, I think the reason is because I think Petidine is easily available in KK and everywhere. All right, and then the problem is like they actually go from one need to get Petidine, right? Because it's not much of you are having pain. The pain.
Sorry, you're very laggy.
All right, I think my
yeah, that's right. Your internet is not stable. Okay, sorry guys. Okay, anyone having problems to scan this QR code?
Better now?
Yeah, better now.
All right. So morphine, we do have patients who require it more when the cancer tumor grow in size. So it's more of dependent rather than tolerance rather than addiction. So let's say you have patients coming in with 2.5 milligram of morphine, and as the disease continues to progress, we know that the requirement of the opiates will increase. So that is not really addiction, it's more of tolerance. The body actually need more morphine because the disease is more progressive. But I cannot deny that, some patients take morphine to sleep because they just want to sleep off and they didn't want to suffer the pain. So I think in just not only the drugs, you also have the psychological support that you need to give it to your patient when you start patient on opioids. There's a question here. What are the types of morphine? So we have short-acting morphine. We have sustained-release morphine. So short-acting morphine, we have the liquid form. We used to have tablet form, but it is no longer available. So morphine liquid formulation depends on hospital. For my hospital, 1 ml is 1 milligram. For most of the Ministry of Health hospital is 1 milligram. 1 ml is 2 milligram. So when you give morphine, you have to really read up the label because it can be 1 milligram with them and 1 milligram with ours is different. All right. Then once we know the stable dose of morphine, for example, in 24 hours, you have 40 milligram of morphine over 24 hours, the liquid morphine. You want to change it to a long sustained acting morphine called MST. All right. So you can do 20 BD with still 5 milligram PRN. We have oxycodone. So the things that you normally heard is Stargin, OxyContin, Oxytocin and Oxycontin, both of them are oxycodone. There's a long-acting. Oxynorm is the immediate release opioids. We have fentanyl. Fentanyl comes in injection, also in patches. So patch, we have 12 microgram, 25 microgram, and 50 microgram. When you start someone on fentanyl patch, be very sure you already titrate them, start them on morphine and know the dose, because I have seen a lot of doctors being patched 25 microgram onto the patient and they actually end up with OD, overdose. Start low, know their morphine requirement. Conversion rate, you can find it in the CPG. Normally, if let's say the patient requires 60 milligram of morphine in 24 hours, you divide by 3 is about 20 milligram fentanyl patch. And patch works every 3 days, and you can only change it every 3 days. And we have, what other opioids? Oxycodone, yeah, oxycodone, morphine, fentanyl. These are the 3 most commonly available in Malaysia.
Okay, so we'll take the last question. Sivadan asks, do you tell relatives that the loved one has a certain number of months to live?
Yes, I do.
You do?
I tell patient as well.
Okay,
Yeah.
how do you gauge? Huh?
Yeah, so we'll know. That's why the oncology part, knowledge about the oncology is very important. So you must know your cancer's disease trajectory. By the time they come to us, most of them are already at the stage 4 disease. If they're in the stage 4 disease, they have 3 to 6 months to live, depending whether they are on any oncology treatment. Things like targeted therapy is actually helping patients to live longer, 1 or 2 more years longer. Some immunotherapy actually help the patients to live about 5 years longer. And it really depends whether you're on ongoing treatment or not. So if my patient have stopped treatment, and I know beside the cancer, they have other problems. For example, it is a metastatic disease. You have a patient that comes in with CA breast, with lung, liver, bone cancer, and now you see that the biometer is, your parameter is, you have hypercalcemia. It's one of very poor prognostication factor. Hypoalbuminemia is one of the very poor prognostication factor. So with this, it will give you at how long, from what time to how long. But I cannot tell you definite. So for example, a patient come to me and I suspect she have weeks to go. How do I know it's weeks to go? Because every few days or every week there is a new symptom or new problem related to the cancer. And I say, okay, now I will tell actually I'm quite honest with my patient. If my patient come to me early, in the very beginning, during my first consultation, I will actually ask them, how honest you want me to be with you? You know, how much do you want to know? Do you have a proxy that you want me to tell everything? Most of them say, okay, tell me the truth, but a lot of them cannot handle the truth sometimes, right? So you also want to know their psychological status. Are they a patient on, are they have anxiety? Are they depressed? So these are the factors that you need to analyze and say, okay, this patient cannot be so truthful. Tell the truth, but don't tell all the truth. Then you want to ask, why do you want to know? I want to prepare. So I will tell you, okay, roughly you have you have short months. I tell them, doctor, why short months? I said 9 months is not short months. 9 months is quite a long months, right? So I said probably 2 to 3 months. So if there's anything that you need to do, you actually need to start preparing for it. I just told a patient that in ICU today that he has very short weeks to live, and I said, it's time to get your things in order. Have you sorted your will? Have you spoken to your wife? Then I spoke to the wife. The wife couldn't accept it. But then the husband said, please tell her, because I can't tell her. So I have to be the breaker of the bad news. All right. So sometimes it's not easy, but I think by being truthful to your patient, it allowed them to prepare some of their unfinished business, sort things out. I have one patient coming in to me and tell me from nursing home and say, doctor, cholangiocarcinoma, very short prognosis. I don't want anything. Promise that when I'm dying, you give me, you make sure that I'm comfortable. So we talk about palliative sedation. Okay. So when the time comes, I give her palliative sedation, and I don't give her any fluid. I don't give IV drip. I stop all my IV drip. Okay. And then she passed away in 2 weeks' time. So you have to know your patient. You have to talk to your patient. You have to understand the patient, so that when you tell them you have 2, 3, 6 months to live, all right, you want to know why they ask that question. I always tell them, is this something that you need to do before 6 months arrive? So most of them, they say, oh, old people no, nothing to live lah. But I said, well, do you want to do some recording? I have a patient that we did recording for them in Beacon. Patient know that she's dying. I said, would you like to leave anything for your children, for your wife? So we actually arranged the marketing side to do recording for her for the last. So it's a secret thing that we do with him. He said, give to them only after I die. Oh, okay, lor. So we actually did a video for different messages.
So sweet.
Yeah. So
That's
she
so sad.
so he actually give every message in that video to the wife, to the son, to the sister, to the daughter-in-law, to the daughter, to the grandchildren, and we took out some of the photo from the handphone to make it into a small presentation. So when patient died during the funeral, the wake and the funeral, we actually told the son, you know, your dad have left something for you. Would you like to have it? Because I think it's going to be very meaningful if you can put it during the wake and funeral. And the son really appreciate what we did because they can hear and see the father even after he passed away. So telling people short prognostication is not that scary, and it's not a bad thing because it gives them time to prepare for the dismissal, and after that how to give the patient family time to grieve properly, opportunity to grieve properly. Yeah. So I hope I answer.
Okay.
Hmm.
Okay, so Sivanan say he always feel God's decide. So of course Felicia is a believer. I'm not a believer. So I don't take God into consideration. Okay, so anyone who has problems with scanning the QR code, please WhatsApp me at this number with your name, your MMC, and your IC number and your email address. I will then send it to the Beacon marketing personnel, which is Fiza, who is here now. She will actually manually do it for us. Okay, and with this, I would like to thank, of course, Felicia and Fiza for making this happen. I think it was a very interesting talk. It actually opens up our mind and also our heart, and also how our perception can change with the more we learn, the places we, patients we see, and really I feel that Beacon is doing a great job with patients care, not just treatment, but overall patients care when it comes to cancer therapy, in terms from A to Z, in terms on family service and acceptance of death, which I think a lot of people would not touch on, even in patients with cancer and doctors treating cancer. We have something. Okay, so we are going to go to another session of CPD next month. We have 4 CPD points to give out, and this time we are collaborating. Beating Heart is collaborating with Sunway Medical Center. So I see you next week again, and Beacon is keen to collaborate with Beating Hearts again, maybe after August, because we have full sessions up to end of August. See you, Felicia. I'm sorry I can't give you the cake tomorrow because the cake sent to me a bit smashed up, you know.
Don't worry. Thank you for your thoughts.
Okay.
Good night, everyone. Thank you, everyone. Okay, bye-bye.
Bye, guys.
Bye.
Thank you so much.